parents and doctor. Welcome to Small Kids, Big Emergencies. Today we're talking about functional gastrointestinal disorders, or FGIDs, in children. These are extremely common presentations in emergency and urgent care settings, but they're also frequently misunderstood. The key challenge for A&E clinicians is balancing two priorities: avoiding missed organic disease and avoiding unnecessary investigations when the presentation fits a functional disorder. FGIDs are now understood as disorders of gut-brain interaction, meaning symptoms are real, physiological, and often triggered by altered signaling between the nervous system and gut. Our aim today is simple: to help you recognize these conditions confidently and safely in the A&E. Functional gastrointestinal disorders are incredibly common. Large studies suggest as many as 1 in 4 children are affected at least once. Such patients frequently present with chronic or recurrent abdominal pain, constipation, nausea or vomiting, or altered bowel habits. For families, these symptoms are distressing and often persistent. For clinicians, the challenge is uncertainty. Often, many children undergo extensive investigations before a functional diagnosis is made. Yet, evidence suggests that symptom-based diagnostic criteria are reliable when red flags are absent. Our role in A&E is setting the trajectory of care for these patients. Functional gastrointestinal disorders are defined as symptoms arising from the GI tract without an identifiable structural or biochemical explanation. But functional does not mean imaginary. Instead, the current model emphasizes altered gut motility, visceral hypersensitivity, an altered central nervous system process, and often psychosocial factors. This is why they're now described as disorders of gut-brain interaction. Diagnosis relies on Rome 4 criteria, which classify these conditions based on symptom patterns. So, what is the gut-brain axis? This describes the two-way communication between our central nervous system, brain, and our gastrointestinal system, gut. Communication modalities include nerve signals, for example via the vagus nerve, endogenous chemicals, for example via hormones and immune cells, and can even result from altered gut flora via serotonin and GABA neurotransmitter release. We know when stressed, our sympathetic nervous system is heightened, and as a result, anxiety can cause tummy ache. Indeed, abdominal pain in return can affect our emotional state. Stress, poor sleep, poor diet, and more besides can result in digestive changes from diarrhea to constipation, from stomach pain to vomiting. To take care of our gut, we must take care of ourselves. In emergency care, several functional GI disorders appear again and again. The most common 5 include 1. Functional constipation. 2. Irritable bowel syndrome. 3. Functional dyspepsia. 4. Functional abdominal pain. And 5. Cyclical vomiting syndrome. Recognizing patterns in symptoms matters, because these diagnoses can often be made clinically. When assessing abdominal symptoms in A&E, the question of functional versus organic disease is crucial. Rather than asking, is this presentation functional, we should ask, is there any evidence of organic disease? Are there any red flags? Functional disorders are diagnosed when symptoms match a recognized pattern, when red flags are absent, and when symptoms have been for a sufficient duration. This is a safety-focused approach that aligns well with emergency care. So, what are these red flags? Important warning signs include any weight loss or poor growth, any gastrointestinal bleeding, persistent or severe vomiting, any localized right upper or right lower quadrant pain, nocturnal symptoms, and any family history of inflammatory bowel disease or celiac disease. If any of these red flags are present, further investigation is required. Without any of these red flags, the probability of serious organic disease falls significantly. So how do we use the Rome criteria to make diagnoses of functional disorders? This may seem complex, but in actuality, it can be simplified. There are always three components. One, that there is a typical symptom pattern. Two, that the symptoms have been present for a defined period, usually over 2 months in children. And three, that there are no alarm features. Let's look at the 5 most common functional disorders. First of all, functional constipation. In younger children, stool withholding plays a major role. A cycle develops: painful stool, avoidance of going to the toilet, harder stool, and then more pain. This pattern is extremely common and rarely dangerous, but it can cause significant distress and repeated A&E visits. This is important. Many people do not know how to ask about constipation. It is not adequate to simply ask a child, "Are your poos normal?" Their answer, regardless, will almost always be yes. Instead, there are a series of questions as per NICE guidelines, and these questions should be asked openly. Take the time to find out. Ask, is there any pain in your bum? Have you ever had blood in your poo? Do you sometimes have pain passing poo? Are your poos ever large and have they ever blocked the toilet? Do you tend to have pain in your tummy? Have you ever had poo accidents? Or do you find yourself bending over with your knees up? It is not simply a case of asking if they have hard poo or if they have infrequent poo. This is all based on NICE guidelines. Only 2 of these symptoms are needed to make a diagnosis of constipation. So you do not have to have hard poo to have constipation. Asking children about their poo is also not likely to result in a helpful answer. So show them this Bristol stool chart and ask them to choose which one is theirs. Again, It's not simply a case of hard versus soft, and not simply a case of less than 3 stools per week. When it comes to examination, check for any abdominal mass, check their spine and sacrum, look at their gait and consider their development. How is their weight? How is their growth? How are their reflexes, their ankle reflexes, their lower limb tone? What's the power like in their legs? And occasionally it might be helpful or necessary to have an external look at the child's bottom, of course with consent and a chaperone. It is not simply a case of feeling the tummy with your hand and magically determining if they have constipation or not. Again, this is based on NICE guidance, and 95% of the time there is no organic cause of constipation. Instead, it is typically idiopathic when there are no red flags and when examination is otherwise normal. Now we are going to look at irritable bowel syndrome. Irritable bowel syndrome is defined by abdominal pain associated with changes in stool frequency or form. In children, this often appears after infections, stress, or changes at school. Importantly, IBS is common in adolescents and frequently presents to emergency departments. 3 high-yield questions to determine if irritable bowel syndrome is likely are: 1. When your child has tummy pain, does it usually improve or change around the time they go to the toilet, or perhaps just after they've been? 2. How often are you going to the toilet? Is this more or less than before? And 3. What do your stools look like? Are they more watery, more lumpy? Are they different to before? Now, let's look at functional dyspepsia. This involves symptoms arising from the upper GI tract. Children may report an early fullness when eating, nausea, epigastric discomfort, and a reduced appetite. It's important not to confuse this with gastritis or reflux, unless other features suggest organic disease. Ask, is there tummy pain or burning that stays the same even if you go to the toilet? This identifies it as being upper abdominal pain. Do you feel full quickly or overly full after every meal, even small meals? And lastly, are these feelings or symptoms recent and infrequent, or have they been every day for some time now? Now we talk about our 4th condition, functional abdominal pain, not otherwise specified. For this, between pain episodes, they are completely well. And when the pain occurs, it can actually be particularly bad. Consider what is going on for them at home, in the family, at school, in their mind. Any worries, any signs of stress. Ask about if it's recurrent. Have they had it before, and how often? Ask if there's any relationship to food or going to the toilet, as this would suggest an alternative diagnosis such as functional dyspepsia or irritable bowel syndrome. Last but not least is cyclical vomiting syndrome. This is a less common condition, but still important to recognize. Here, children experience intense vomiting episodes lasting from hours to days, and between they can have completely normal asymptomatic periods. Many children also have migraines associated. The key in A&E is recognizing the recurrent episodic pattern. If parents say, "It's always the same, starts in the early morning, he vomits non-stop for a day, then stops," that's a red flag for cyclical vomiting syndrome. Consider these questions. Do the vomiting episodes start suddenly? Are they very intense and look similar each time? Between these episodes, are you completely back to normal, without nausea, without vomiting, with normal appetite and normal energy? How long are these episodes? Do they last from a few hours to a couple of days? How frequent are they? Tell me about the last 6 months. And finally, are there any triggers? Do they happen after periods of poor sleep or recent infection or stress? All of these point to a diagnosis of cyclical vomiting syndrome. Management in the A&E should focus on 4 priorities. Explanation of the diagnosis clearly. Reassuring families when there are no red flags and explaining that symptoms are real but not dangerous. Where possible, providing symptom relief according to guidelines. And of course, ensuring appropriate follow-up so that further care can be provided outside of an emergency setting. Education and reassurance alone can go a significant way to improving outcomes, and this matters. The 2 biggest harms in dealing with functional gastrointestinal disorders comes from 2 elements. The first, missing red flags and missing organic disease, and the second, excessive investigation that increases patient anxiety and medicalizes symptoms. A careful clinical assessment combined with the use of Rome criteria can help clinicians diagnose functional disorders and stay in the safe middle ground. Functional GI disorders are common in kids presenting to emergency care. Diagnosis relies on recognizing symptom patterns while screening carefully for red flags. When used appropriately, Rome 4 criteria can support confident clinical diagnosis. Importantly, how we explain the diagnosis can shape the child's future healthcare journey. The A&E encounter matters. Thank you for watching this video that bridges mental health and physical health as part of this ongoing series of videos on small kids, big emergencies. Thank you. Please consider subscribing and joining for future videos coming soon.